Good afternoon and welcome to today's webinar, Supporting Health Center Transformation with Social Determinants of Health Data Using Prapare. My name is Jennifer Trujillo and I am the Substance Use Disorder and Special Populations Program Manager. Nevada Primary Care Association is a nonprofit organization dedicated to improving access to high-quality, community-based, affordable primary health care in Nevada. We provide training and technical assistance to health centers and community partners to improve access to healthcare for all, especially the underserved population. For more information, visit us at ndpca.org. This training is a partnership between Nevada Primary Care Association and the National Association of Community Health Centers. I just wanted to take a moment to thank them for helping us coordinate this session. Before we get started, I would like to go over a few items so you know how to participate in today's event. During the presentation, please make sure to mute your phone or computer so that we don't have any feedback or background noise. Also, please be sure not to put your phone on hold or we will hear your hold music. You will have the opportunity to submit your questions to today's presenter by typing your questions into the chat panel. You may send in your questions at any time during the presentation. Questions will be collected and addressed during the Q&A session at the end of today's presentation. Today's session will be recorded and slides will be available to participants. I would now like to introduce today's speaker, Michelle Jester. Michelle is the Deputy Director of Research at the National Association of Community Health Centers, where she helps health centers build community-based and patient-centered research and data capacity. Currently, she focuses on helping health centers collect and use social determinants of health data to improve care delivery, inform policy, and accelerate community change by developing, testing, and implementing the standardized social determinants of health protocol known as Prapare. Previously, Michelle conducted clinical research at the Johns Hopkins University. She received her master's degree from the Australian National University in Culture, Health, and Medicine. Please help welcome me, Michelle.
Great. Hello, this is Michelle Jester. Can you guys hear me?
Yes.
Great. And just to confirm, are you seeing the slide, the full slide?
You see the slides, the Prapare
Perfect.
slides.
Okay. Okay. Thank you so much for confirming that. Thank you so much, Jennifer, and thank you to the Nevada PCA for inviting me, and thank you to all for joining. I'm really excited to be here today to talk to you guys about how you can really incorporate social determinants of health data collected in your workflow and then really apply the data to inform your operations. So I have been with NACHC for about 8 years, and I was a part of the Prapare project since we began. So I helped develop the tool, and I have been alongside health centers and PCAs and networks as we've all been trying to figure out how to build the EHR templates, how do you really fit this into workflow, and how do we really use this data for action. So it's been a real team effort, so I am speaking on behalf of a very large team here. I'm curious to know, and you can think amongst your teams or amongst yourself, but how many of you have really struggled with certain parts of your patient population that it just seems that no matter what you do, it's just really hard for them to either come to the clinic or it's just really hard for them to manage their diabetes or follow the treatment plan that you worked really hard to set out for them. And in a lot of cases, it isn't because the patient isn't willing or doesn't want to, but it's because of all of these structural barriers or these social determinants of health that are occurring outside of your walls that are really hindering their ability to live healthy lives and to make healthy choices. So one reason why we really wanted to develop Prapare is to allow you guys to better understand your patients and then be able to use this data at several different levels, as you see on the slide here, to better provide appropriate care to your patients and then use it so that we can advocate for systems that better incentivize and sustain more upstream work. So at a very individual level, if you use Prapare and discover that even though you may have prescribed a patient of yours some medication, they may have never filled the prescription, they may have filled the prescription, but they didn't have stable enough utilities such that their refrigerator stayed on all the time, so maybe the prescription kind of went bad and so it wasn't effective anymore. That there's lots of ways you can incorporate social determinants data into an individual treatment plan for your patients. At a larger, more organizational level, if you have data to understand the needs of different parts of your population, you can use that to then figure out how better to allocate limited resources. Or if you know you only have a couple of care managers, how do you best utilize those care managers to focus on the at-risk patients rather than using them on your entire patient population? And social determinants can help you do that. At a higher level, knowing what the needs are in your population and your community can really help you establish partnerships with those community-based organizations, those social service organizations and whatnot, to provide services that meet the needs of your patients. And then on kind of a larger level, what we're really hoping to do with this data at a state and national level is to really make the case that health center patients are different. They are more complex. And therefore, they need a different model of care. They need different services, all of these things that health centers provide but often aren't reimbursed for. So a lot of the enabling services that you guys are already providing, such as like translation, transportation services, case management, huge services needed by our patient population, but currently often aren't reimbursed. So we want to use this data to make that case and then to show the effectiveness of this unique model of care so that we can advocate for more sustainable payment systems to ensure that focusing on non-clinical factors is a more reimbursable and a sustainable model of care. We also want to use this data to help prepare health centers for value-based pay and to better demonstrate the value of health centers. So if you kind of walk through this little roadmap of a slide here, in the current context, we have all of these social determinants of health that are ultimately some of the root causes of poor health outcomes and poor health behaviors. But once we can better understand our patients using Prapare, we can understand what's impeding them from being able to make those healthy choices. With that, we can move on to transform care by providing more non-clinical services, either in-house or through community partnership. We can rethink about our care teams and think about if we need more non-clinical providers or if there are ways that we can utilize our clinical staff in order to do this. And then we have more empowered patients. Once we're transforming our care and being able to document that, we can then better demonstrate the value of health centers, which today is a very important thing to do in a very uncertain kind of government funding environment, that the more that we can prove that we are a good investment and have good return on investment, then the better and more easy it is to make the case on the Hill that health centers definitely deserve to receive more federal funding. And then again, finally, as I mentioned before, we definitely want to use this data to come up with better payment models and for risk adjustment models too, so that providers such as health centers who are serving more complex patients aren't being penalized for doing so. So this leads us to Prapare. So Prapare stands for the Protocol for Responding to and Assessing Patients' Assets, Risks, and Experiences. And this was an initiative that started back in 2013. We at NACHC started it in partnership with the Association of Asian Pacific Community Health Organizations, or AAPCHO, and the Oregon Primary Care Association. And as I mentioned earlier, we worked very closely with several different health centers and health center networks and PCAs to develop Prapare and then test it in the field. But several unique things about Prapare is that it is a national standardized patient-level social determinants of health risk assessment tool that is built into the electronic health record, and it was designed to really engage patients in this process. So we don't view Prapare as a static survey tool that you go through question by question, but we view it as a tool that you can use to build better relationships with your patients, to better understand them, have more empathy with what they're going through, and then better understand them to provide more appropriate services. We also view Prapare as a customizable and flexible tool that, again, for us, it's not about using it as a survey, but it's more about using it as a way to have a conversation with your patients. So we started developing Prapare back in 2014, and we spent an entire year just building the paper tool of Prapare. Once we settled on what measures we wanted to include in Prapare and how to ask the questions, we then worked with the health centers and the health center networks to develop several different electronic health record templates for Prapare, and then we tested it in several different workflows. And one thing we learned was that you can use any kind of workflow to implement Prapare, and I'll walk through some examples a little bit later on, but that there's really no right or wrong way to implement Prapare and collect this data. It's really a matter of what fits best in your own setting. In 2016, we spent some time harvesting all of those lessons learned from the pilot testers and the best practices, and we included them in what we call a Prapare Implementation and Action Toolkit. So this is a free resource that's available to you guys. I have a slide on it here in a little bit, but it's on our website, and it really walks you through all the steps that you would need to take if you wanted to collect social determinants of health data in your own setting, from strategizing the process to actually collecting the data, and then evaluating and analyzing the data, and then really applying the data for action. What we've been doing the past couple of years is that we've been really focusing on trying to support spread and impact. So we're working to spread Prapare to more populations, so learning more about how to use Prapare with homeless populations or veterans. We're spreading it to more states, but then we're also doing research to demonstrate the impact this has had in terms of having this data and then being able to respond to this data. And we're also doing research to show the impact that social determinants has on outcomes and costs. So when we developed just the paper tool of Prapare, we went through a layered process. So the first step of this process was that we wanted to make sure that whatever was included in Prapare was based in the literature in the sense of which social determinants were linked to higher healthcare costs and poorer health outcomes. After we did the literature review, we also did an environmental scan of existing patient risk assessment tools. And what we found back in 2014 was that while there may have been several different types of social determinant assessment tools in existence, the vast majority of those were homegrown tools. So one that a health center or an organization may have developed for their own organization, but it wasn't necessarily validated. It wasn't built into the electronic health record, and it wasn't really widely used outside of that organization. So from that, we definitely saw a need to develop a national standardized tool that was built into the electronic health record. We had a very engaged stakeholder process throughout the development of the tool and the testing of the tool. We had an expert advisory group that consisted of health center patients, some community health workers, health center leadership, clinical staff. We had a payer. We had CMS, someone from CMS on our expert advisory group. So we definitely wanted to make sure we were capturing all the different perspectives and feedback from lots of different roles and from lots of different audiences in the development of this tool to make sure that what we were focusing on was a priority to the stakeholders, that the questions were worded in a sensitive way so that patients felt comfortable answering them, and so that providers or staff felt comfortable asking them, that the tool was comprehensive enough but not too burdensome to implement into workflow. Like, these were all key questions that we discussed with this expert advisory group. And then finally, throughout this development process, we wanted to make sure that whatever we developed aligned with other national initiatives that were occurring at the time, because we didn't want to develop a tool that would ask you to collect slightly different information than what you may be required to collect for another initiative. So we definitely monitored the Healthy People 2020. We aligned Prapare with ICD-10 codes and with meaningful use and whatnot. So after that process, we came up with the following social determinant domains that you see on the screen. So the core of Prapare consists of 16 different measures that you see on the left-hand side of the screen. And as you'll see, 9 of these measures already align with UDS. So you are already collecting these measures, and with the electronic health record templates that we developed, you do not need to collect that information again. We definitely want to avoid double documentation, and so what happens is that the EHR templates map to your practice management system or map to wherever you have your demographic information, and pulls that into the Prapare template just so you can have that fuller socioeconomic picture of your patient. But just to be clear that you do not need to re-ask all of your UDS questions. We just like having them there to have a full socioeconomic picture. In addition to the core element, so in reality you're only asking 6 new questions on the core, we also have a set of optional measures. We have a set of optional measures on some domains that you see on the right. So those include safety, domestic violence, refugee status, and incarceration history. And those were domains that some people thought would be important to be able to capture data on, but that didn't necessarily need to be a part of the full core tool, if that makes sense. That if it's meaningful for your community to have data on that, you have the option of collecting data using those measures. We also have a set of optional granular measures to get a little bit more at how many jobs someone might work or how many hours. In this day and age with some of the Medicaid Alone 15 waivers on work requirements, that data might come in handy to help prove that people are indeed working, so are still eligible for Medicaid. We also have some granular questions on insurance and social support as well. And some exciting news that we've been working on 10 different translations of Prapare. Those languages include Arabic, Burmese, Chinese, so both simplified and traditional Chinese, Korean, Spanish, Portuguese, Vietnamese, Tagalog, and I am missing one, but we had those translated by a professional translation company. What we've also been working with different health centers who have large populations that speak those particular languages, and we've asked them to review them. And most health centers have come back with some edits, and so we've been incorporating their edits into this process as well. And we hope to release those at the end of this month, so stay tuned for that. Just for the sake of time, I'm going to bypass that. So we have several different Prapare EHR templates that are available and are free. We have Prapare EHR templates for NextGen, eClinicalWorks, TE Centricity, Epic, Cerner, and Greenway Intergy. And we're working on Athena, Allscripts, and Meditech. But I looked at UDS, and it seems that most Nevada health centers were either on NextGen or eClinicalWorks. If there is someone that is not on one of those EHRs, if you're on a different one, please put that in the chat, and I'm happy to make sure I cover that particular EHR. But from what I was able to gather, it seemed that most of you are on eClinicalWorks or NextGen, so I'm just going to dive into those two templates. So for NextGen, we currently have a template that was developed by NextGen, and OSIS, the Health Center Network, was heavily involved in that development, but it's currently a standalone template. However, NextGen has been working extremely hard to build Prapare into their base product, and they plan to release that in May of this year, so just next month, so that's very exciting. And by having it built into the base product of NextGen, it's compatible with the latest KBM, or now they're calling them ACE, like ACE, or I'm not sure what that stands for. But it would allow you to better integrate your Prapare data with their population health management tool. So it allows you just much more like analytic power and being able to slice and dice the data. There's also a vendor that several health centers have been working with called OTEC, that if you want to build Prapare onto a tablet or iPad system, that OTEC has been the vendor of choice to do that, but just know that it comes at $1,500 per configuration to do that. So per organization across all of your iPads or whatnot, it would cost $1,500. For eClinicalWorks, we have two options. One is that we have a free configuration guide that does a great job walking you through the steps that you would need to take if you wanted to build Prapare as structured data into your social history section. That is free, and that is available on our website in Chapter 4 of our toolkit. We also have a smart form that is available for Prapare and eClinicalWorks. Unfortunately, eClinicalWorks is charging $1,000 per organizational system for that, so just be aware of that going into it. However, we do have the free configuration guide if you want to bypass the smart form. To be honest, there are trade-offs associated with each. There's no right or wrong. I think it's more a matter of what matters to you. So with the configuration guide, obviously that allows you some more flexibility or customization, that if you wanted to add other questions, you're able to do so. If you are an organization that you would prefer to have all of the information in one place and have it easily automated into a report, the smart form might be the better way to go for you. The smart form also incorporates part of our Prapare risk scoring methodology. It's very basic at this point. It's not weighted, I will admit. It's more of if a patient has a risk, they get a score of 1 or 2 depending on the risk. And so what that smart form does is that it will tabulate all of that at the end. And so you can use that to risk stratify your patients, if you like, by their Prapare risk scores. Oh, and there's also recorded demos of how to use each of these Prapare EHR templates that's available at our website that you see at the bottom of the screen there. Okay, just a couple of screenshots of the eClinicalWorks social history. Again, there's instructions available at our website, but just kind of a general sense of how you can add some of these questions and what it kind of looks like in social history. Here is a screenshot of the smart form in eClinicalWorks, like where you can find it, see where the arrow is pointing in the drop-down menu, that once you get it configured, it will appear there. And that way you can use it that way. Some things that we've learned from Prapare is that it really is not hard to administer, and it really kind of depends on how you administer it, but staff and providers really appreciate using it. So staff really like using it because they feel like they better understand their patients and allows them to build relationships with their patients. Providers really like it in the sense that by having staff focus on some of these non-clinical barriers, the providers are better able to focus on the clinical aspects, and so that their treatment plans can be more effective once social determinants data are taken into account. I mentioned this before, Prapare can be used using multiple workflows. There's no right or wrong way to do this. And lots of situations, like we know that health centers know their patients well, but Prapare has discovered and uncovered new needs that health centers didn't realize that they had. In one instance, we were working with some California health centers, and they discovered that childcare was a huge need in their patient population that they had no idea existed. So they found that it really helpful for them, and they would never have known unless they asked the question. We have found that Prapare is very actionable, that we have lots of examples, and I'll talk about some, where change can happen immediately once you have this knowledge, and then using this for also more longer term change as well, but it's really leading to positive action. So just some examples of how Prapare data has been used to really kind of address social determinants. There are a couple of ways of thinking about this, and again, there's no right or wrong way. Some health centers really like to think about what they can provide in-house, and so after using Prapare, they may have started or enhanced like their food banks at their health center, or maybe they have like a clothing closet where they can get donated clothes. Some have started book corners, but in other cases, health centers are really using this to have better relationships and partnerships with the community partners and what exists in their community. So in some instances, we had some health centers in Iowa that when they found out, or when they started using Prapare, they found that 1 in 5 of their patients were having a transportation issue. And they didn't realize it was that bad. They knew they had a transportation issue because they would always run out of bus tokens and taxi vouchers before the end of the year, but they didn't realize it was 1 in 5 of their patients. And so what some people at the health center have been doing is that they started going to their local transportation agencies meetings and learning more about what the transportation agency does. They've been introducing themselves and having them come toward the health center so the transportation agency can learn more about the health center. And from that relationship that they built, they were able to negotiate bulk discount rates for more taxi vouchers and bus tokens. And they've also geo-mapped the data to highlight those areas in their community that are experiencing the biggest transportation barriers. And they're now able to use that to advocate for new bus routes to those areas. And again, they would never have been able to do that without the data. We have some instances, because I know some of you may be in rural areas, and sometimes there's always a concern that if I'm in a rural area, you know, there's just not as many resources available in my community, so what are we going to do? We have another example of a rural health center. This was in Massachusetts, that they were 60 to 70 miles from Boston, so they were in a rural area. And after using Prapare, they found that food insecurity was a big need, and they didn't have a food bank in their community. But on a chance, they called a food bank in Boston and was able to share the data with the food bank in Boston. And because they were able to demonstrate the big need of food in their community, the Boston Food Bank was willing to have a weekly delivery, an 18-wheeler weekly delivery of fresh foods and non-perishable goods that, again, that they deliver weekly. And so that's been a huge benefit for the health center and their community that they were able to use with, that they were able to make happen because of Prapare data. We had another instance where a health center in Ohio, this was kind of like in the Appalachian region of Ohio, where the opioid epidemic is quite severe in that area, and they were using Prapare with expert, so they kind of incorporated Prapare and integrated it with their expert assessments. And they had their nurses administering Prapare, so the nurses were the main staff doing this. And in one situation, a particular nurse had helped a patient and helped her address her needs. And then in one instance, the patient was back at home and was experiencing a bad domestic violence situation such that she left her home and walked 20 miles barefoot back to the health center because she knew that the nurse that had helped her with her other needs would be able to help her with this particular need as well. So you really just, in some cases you can quantify what it means, but in other cases you can't quantify the value that these kinds of conversations can have on building relationships between yourself and your patients. And on a larger level, we've had health centers and PCAs, like they've been doing some return on investment analyses to better understand the value of some of the interventions they've been implementing. So there was a health center in Missouri that they knew their no-show rate was extremely high. I believe it was getting close to 40%. It was in the high 30s, I believe. And so with that, they were able to calculate how much missed revenue they had because of the no-show rate. They implemented a transportation intervention and were able to track how much they were able to reduce the no-show rate. And as a result of increasing the number of visits by decreasing the no-show rate, they were then able to calculate the money generated with this. So I think sometimes when people hear about ROI analysis, they think it needs to be this really big, complicated thing, and it is in some cases, but in other cases it's also just kind of demonstrating the value of an intervention like that transportation intervention, that it can have a really powerful impact and message on the importance of doing this kind of work. And what's happening now, which is interesting, is like increasingly more hospitals and health systems, health plans are using Prapare, and Medicaid is now very interested in Prapare as well. And what's been happening is that because of health centers' experience using Prapare and collecting and using data, in many instances, Medicaid agencies are coming to health centers and the PCAs and learning from their experience. So in North Carolina, like the PCA and the health centers there were very influential in informing the development of the North Carolina statewide Medicaid social determinants of health tool, that they used a lot of Prapare questions because they had been tested. So there's huge opportunity for you guys in Nevada to be leaders in your state by focusing on social determinants often before others in your state are doing so. And so that gives you the advantage of then being able to inform the policy and practice moving forward. I mentioned the toolkit earlier, so here's a slide on the Prapare Implementation and Action Toolkit. Again, this is completely free. You can find it at our website, which is up there on the slide. And again, it walks you through the steps that you would need to take if you wanted to collect and then use social determinants of health data. So the first 3 chapters are really about the strategizing of this process. So how do you engage those key stakeholders? What kind of messaging do you use? What kind of script should you use with patients to, let them know why you're asking these questions, those kinds of things. We then have a section on actually collecting the data. So that's where you can find the electronic health record templates. We have a series of workflow models that kind of walk you through all the different scenarios of workflows that you can use and then the trade-offs associated with each. Again, no right or wrong, it's just whatever fits best in your setting. And then we start talking about how you can really understand, evaluate, and analyze your data. And then the last section is about, okay, now that you have this data, what do you do with it? So there's some chapters on how you can build capacity at your health center to do this, some sample interventions that you can use within your clinic, in your community, and some that are clinical and some that are non-clinical. So we try to give you some ideas to get the juices flowing for that. And then we have sections on how you can track enabling services. So why Prapare? I've kind of covered this, but Prapare is widely used, and it's the most common tool used by health centers, and it was developed by and for health centers. But again, increasingly more other organizations such as hospitals, health systems, health plans, Medicaid, they are also interested in using Prapare because it's not only evidence-based, but it's also tested and vetted in the field. We have the free resources that we've gone through already. And again, Prapare is very flexible. So it can be workflow agnostic, and it can also be administered in a more conversational way. Again, we don't want you to use Prapare such that you are asking each question word by word, by rote memory, if you will, but it's more to us about having a conversation with your patients and then standardizing the need on the back end. So to us, it's more important that you use an empathic inquiry approach, a motivational interviewing approach, and whatnot to have these conversations with your patients. We have mapped and linked Prapare measures to ICD-10 Z codes where they exist. There are some major gaps with the Z codes, but we've also been working with United Health Group to develop additional recommendations for Z codes to fill in those gaps. Many of the EHR templates automatically map to the Z codes. The NextGen template does. eClinicalWorks unfortunately does not. I'm sure all you eClinicalWorks users know that sometimes it's difficult to get ECW to do things, so we've run into similar issues, but we're still working on that. But we do have a document that maps all of that, that if it was really important to you to have those codes on the back end, we have a document that allows you to know which code to put in. I see there's a question in regards to LOINC. We have mapped Prapare also to SNOMED and to LOINC codes, and we are also working with Registry to create LOINC codes for Prapare specifically as well. So that process has started. We've been told it might take a couple months to complete that process, but know that that is happening. Okay, the value of prepared data. I'm going to go through this a little quickly, but just to give you a snippet of some of the data that we've learned from this. With this graph, you will want to focus on the peaks, so where the lines are kind of highest. What this graph is showing is the number of social determinant risks that the percent of the population is experiencing. So these are health center patient populations. You can see the sample sizes on the right. These are from some of our pilot testers. But we separated the data into patients that were high risk, so those that might have multiple comorbidities, those that might be seeing a chronic disease management team. We separated the high risk patients from the general population patients. And what you can see is that on average, 20% of health center patients are facing between 4 to 6 social determinant risks. So again, that's 1 in 5 of health center patients are facing multiple social determinant risks. And these can be risks like unemployment. These could be risks such as food insecurity, homelessness. You know, these are not insignificant risks. So it really makes you think about, like, again, how are you supposed to manage the conditions of these populations when they're also having to deal with all of these non-clinical risks as well. If you look at the high-risk group, which is the red line, you can see that 10% of patients are facing around 8 to 9 social determinant risks. So again, like 1 in 10 of your patients are facing 9 risks. You know, like it's just one of those things that this is why we can't ignore social determinants. And I can understand a health center can only do so much, but just having a better understanding of your patients in this regard can really help inform the treatment plan, the care model that you might have, the community partnerships that you might set up in the future to help addressing some of these risks. So we think that this is really valuable, that if you have prepared data in terms of the number of risks that someone faces, you can also use this for kind of risk segmenting your patient population and helping to triage your limited resources to focus those that might have certain risks or might have more risks than others. This shouldn't come as a surprise to any of you, but we've learned that as the number of social determinant risks that someone faces, the more likely it is that they have hypertension. That is not a surprise, but it's nice that we now have the data to prove that. So that's what that graph is showing. We also did some patient-level analyses working with a health center in Iowa and found that uncontrolled diabetics had more risks than just their regular diabetic population, so their controlled diabetics versus uncontrolled diabetics. Again, not a surprise, but something interesting that came out of this research is that for every one increase in a Prapare risk score, so if a patient increases from having 2 social risks to having 3 social risks, or from having 5 social risks to 6 social risks, so for every increase, there is a 13% chance more likely of them becoming an uncontrolled diabetic. So there's a direct correlation between the number of risks that someone faces versus the likelihood of them not being able to control or manage their chronic conditions. And so again, we can use that to have better ways to address social risks before they become more downstream effects. So address these risks before it leads to poor health utilization, poor health outcomes, and whatnot. So here's an example of using prepared data for risk segmentation. So in this example, like, you know your population. So that's your population on the left. Then if you segment that to a subpopulation of just your diabetic patients, you have, you know, the colored dots that's in the middle. But then if you segment that to just your uncontrolled diabetics, and then use Prapare on those uncontrolled diabetics, you can then have a better understanding as to which of your uncontrolled diabetics and how many are having transportation issues or are having food insecurity issues. You know, so it really allows you to drill down and better understand what might be going on with some of your hard to manage patients. So I wanted to leave you with some tips for getting started before we stop for questions. I know that collecting social determinants data and then really responding to needs can sound like a big lift, and it's not insignificant, but something that I hope that you all realize is you're probably already doing a lot anyways, but it just may not be standardized. So if you know your population well, you know, that's social determinants work, but you just don't have that standardized data in your system to then, you know, take that next step or make the business case to do certain things. And I can also appreciate and understand that most of your missions, if you think about the mission of your organization, I would think inevitably it touches or involves social determinants in one shape or the other. If we have missions related to providing care for all, addressing health inequities, you know, all of those things really come back to social determinants. And so it really is part of the health center model that even if we don't have the resources in-house to address all of these things, it is part of understanding our patients and then doing the best that we can to address those inequities that they're facing each and every day. But I would say some tips for getting started are to first, I think, complete a Prapare readiness assessment. We have free Prapare readiness assessments, one for health centers and one for PCAs as well. That it's a really helpful exercise to kind of get the conversation going at your organization to figure out where do you have strengths in terms of your staff, the culture of your organization, your technological capacity, and whatnot, and then where you might have some gaps that you might want to focus on or build up before you start down this path. That would be a first step, I would say. The next step, obviously, with any initiative, you want to engage your staff and your leadership and your patients. But I think a key way to engage them is to not say you want to do this new project, because we don't think that's the right language to use. And actually, we wouldn't say that. We would advise you to not mention this as a project, but as something that would really add value to things that your organization is already doing. So if you have initiatives that are focused on improving quality, you know, how could social determinants data really help inform that? And it could a lot. It very well could. Prapare data could be used in team huddles. You know, it could be used to inform the care plan. You know, there's lots of ways you can do that. If you have a project that's focused on diabetes, you know, how can social determinants data really help you with your diabetes project in terms of if your goal is to, you know, improve your diabetes rates or, you know, lower the A1C levels, you know, how do social determinants play into that? I know many of you are focused on opioids, so again, how can social determinants help not only help address the opioid epidemic writ large, but then also better understanding what might be leading your patients into substance use disorder and opioid use as well. So again, social determinants really kind of underlie everything. That's a great way to think about how you can add value to things you're already doing, and also a way to fund this work too, that if you have certain projects that are focused on these various topics, you know, social determinants underlies all of that, that's a way to potentially build in time for people to focus on social determinants. A trick that our partner at the Oregon Primary Care Association used that might be helpful for you guys is that when engaging their staff and leadership at the health centers, they advocated using a 3x10 approach. And with that approach, all that was involved is that they gathered some staff together, and as a group, they just picked 3 questions from Prapare. So just 3, so it seems very manageable. And with those 3 questions, they just asked 10 patients. So each staff person asked 10 patients those 3 questions. And what happened was that with that small exercise, it really allowed staff to see how they could really apply this data to their daily, you know, operations or responsibilities. It really made them feel more at ease in terms of seeing that patients were comfortable answering these kinds of questions, and that patients really appreciated being asked these kinds of questions because they feel like they're being considered more as a whole person rather than just a condition. And so I think that's a great way to kind of get your feet wet in starting out with social determinants of collection. So something to keep in mind. I'm going to come back to this slide, but just some ways you can frame this to staff and leadership is, first and foremost, I mean, it depends on the audience, but everyone should be able to respond to the first message, and that, you know, Prapare will really allow you to better understand your patients so that you can provide the best possible care. Another message that you can use is that Prapare data can really help you demonstrate your value in a very uncertain time in terms of funding. Another message that you can use is that Prapare can provide you with the data that you need to inform risk adjustment and alternative payment methodologies so that you guys will not get penalized for serving more complex patients. And so there are payment systems that are actually paying you for a lot of the services that you're already providing. And then Prapare can add value to other work that you're doing, which we've talked about already. I know there often are common questions that we get, so I like putting those up here and some of the responses that the health centers, the early adopting health centers, kind of came up with. So we totally understand if there are other initiatives going on in your state that might require you to use another social determinants tool, like what do you do in that situation? And again, we don't want you to have to collect very similar data for different initiatives. So one thing you can do in that situation is do a crosswalk of what's required for the particular initiative you might be involved in, and then crosswalk it to Prapare. And I think you'd be surprised at how much alignment there probably already is. And in a lot of these situations, if it's required of a health center to do an initiative, oftentimes that social determinants assessment is only on paper. It's not built into the EHR. And so there are ways that you can use Prapare to kind of capture the data in the EHR, but that you're also still filling out the paper form needed for that initiative or something. But again, if you have stuff on paper, you're likely not really using it beyond what you just have to for that initiative. But again, if you're also have it in the EHR and the Prapare template, then that lets you just use that data beyond just that one initiative. We completely understand that health centers are super busy. You guys have so many things going on that how in the world are you going to add one more thing to your long list of responsibilities? But again, I think it's about finding the ways that Prapare really adds value to work that you are already doing and starting small. How do you do this without increasing visit time? That's a very big concern. We totally hear that. Some of the best practices we've learned is to find that time when the patient would otherwise be waiting to administer this. So potentially while they're waiting in the waiting room is a good time. Potentially after they've already been roomed, but before the provider has come in is another time that you could potentially do it, or you could do it after the visit. Again, concerns about inability to address SDH. That this is actually from a health center in upstate New York that said this, but even if you don't have resources right now to be able to respond to needs, you have to start somewhere, and you won't know what the needs are until you ask. And I think as long as this is messaged to patients in a way that is about trying to better understand them and what their needs might be so that you can use that information to plan for new services or new partnerships, again, I think patients are very willing to talk to you about that. We know that staff turnover is a big issue, and so we would advise that it's not just held within a particular person or two, but that there's a team of people so that you can have that institutional knowledge and spread across other staff if there is some turnover. And then fitting Prapare into workflow. Another trick with this is that if you have other assessments, like I mentioned ESPER, but if you have, you know, your PHQ screenings or your patient activation measure or whatnot, you know, that how can you integrate Prapare with some of those other assessments too. So going back to this slide, the next set of steps is crosswalking Prapare with other data that you may already be collecting. So we kind of talked about this already, but again, you might be surprised at just how much information you may already be collecting. It's just not necessarily in your EHR. So by doing that crosswalk, you can potentially find opportunities to then use Prapare, and then you have that data standardized and in your system. Selecting a population of focus and determining your workflow model will be really important because that might impact what model you choose. So if you are deciding to focus on patients with substance use disorders, then your workflow model might become your behavioral health staff or whatnot. However, if you were focusing on patients with diabetes, then maybe it's your chronic disease management team or your care coordinators or whatnot that might be doing this. You guys all know this, but testing Prapare with a small group, so doing PDSA. And another key thing is reviewing and updating your community resource guide. We know that most of you probably have this as part of PCMH, but I guess this is always a good opportunity to kind of review that and see how updated is it? Does it seem pretty accurate? Does it seem like we have the right resources depending on what the needs might be? So this is a good opportunity to kind of like review that and double check, or have someone, even some patients, because patients are often really knowledgeable about resources in the community, you know, kind of ask them if there's anything that you may not be as aware of. And then thinking about how you will share and use the data as well. So I'm looking at the time, so I do want to walk through this one slide and then I will stop and take questions. But when you're thinking about your workflow model, we think it's really important to use the 5 rights framework. So the 5 rights are kind of asking those key questions of who, what, when, how, and where in terms of determining your workflow model. So in regards to the what, again, what information are you already collecting? Is some of it part of registration? Is it part of other health assessments or initiatives? With the how, you will want to think about how do you want to administer Prapare? Would you prefer that it's self-assessed, such that the patient's filling out a paper form or on a tablet or in the patient portal, you know, filling it out on themselves? Or would you prefer the staff person administer Prapare with the patient? Something else to consider is who. So who amongst your staff will be administering and Prapare, and then who will respond to the needs identified? Would you prefer that your non-clinical staff do this? Would you prefer that your clinical staff do this? Do you want to spread it out across a couple of different staff, such that maybe your front desk staff ask a couple of the questions and put in the practice management system? Some other staff ask some other questions and then put it in the EHR. When do you want to do this? You know, when is the best time to do this? Is it while the patient is in the waiting room? Is it while they are in the exam room but still haven't seen the provider yet? Is it after the visit with the provider because you don't want to delay the visit with your provider? And then finally is the where. Is your waiting room set up in a way that there are some private spaces for a staff person to have this conversation with your patients? Is there an empty office that can be used for this? Or again, is the exam room really kind of the only private place to do this? Because sometimes I think patients just wouldn't feel as comfortable having these conversations in an open waiting room if there wasn't some private area. So something to consider. I have a couple other slides, but let me go ahead and look at a couple of questions first. So I see a question. Should the Prapare question be used at every visit, and is there an appropriate age range to use it? That's a great question. So we do have, so in the same document that shows the mapping of Prapare to ICD-10, SNOMED, and LOINC codes, we also have a recommended frequency for Prapare. So because some questions you only need to ask once and they won't change. Some questions we think are probably good to ask every year. Questions like education, questions, I guess education is a good example of that. But some questions we do actually recommend that you ask at every visit. Questions like material security, questions like stress, depending on the housing status of a patient. You know, if they answer that they're housing insecure, maybe the next time you see them, you want to ask them the housing question again. But we know that that can be a lot. So the general rule of thumb is annually to administer Prapare. Some of the EHR templates do have alert or trigger systems such that it will alert the staff or the provider that a patient is due for certain Prapare measures, but eClinicalWorks does not do that, unfortunately. And in regards to age range, Prapare is geared more towards adults, I would say, but we have had lots of health centers use this with their pediatric populations. And there's just some best practices on using this with pediatrics in terms of potentially rephrasing the questions, because you wouldn't ask a child like what their income is, obviously, or is using this in conjunction with their caregiver. We are working with a health center to come up with a more pediatric-focused version of Prapare, such that we'll have some additional questions that might relate more towards school environment and safety and that, and potentially more things around food and whatnot, but we don't have that as of yet. Just making sure if they're listening to the link codes, I asked that. And I see that there are a couple of health centers that are on different EHR templates, mostly Henry Schein, some MicroMD, and NetSmart. So I have started conversations with NetSmart, but we are in the very early stages in regards to NetSmart. MicroMD, I have not actually had any conversations with that particular vendor. So what's been helpful in the EHR development process is that if you guys have contacts at those particular vendors, if you would be willing to share them with me, or if you want to share them with Jennifer or Brandy and they can share them with me, that's a great first step, is that I'm happy to kind of be the go-between between you guys and the vendor. Like, I can work with the vendor to develop the template, but then obviously loop you guys in when it comes time to test the template and make sure it really fits in the workflow. Or you guys can also be involved in the development process, so like the stakeholder engagement process. So if you guys would be willing to share your contacts at those vendors, then we can start reaching out to them and let them know that several of their clients are interested in this. You know, would they be willing to develop it and whatnot? So I'm happy to do that if you guys are interested. So feel free to keep putting questions in the chat box. There are some other slides in here you guys can take a look at. This chart here just kind of shows, again, that there's no right or wrong way to implement Prapare, that you can use non-clinical staff, clinical staff, care coordinators, any staff, self-assessment, and there's just different reasons for that. I did want to put this slide in there, that this is all in Chapter 5 of our Prapare Toolkit, that we walk through each available workflow model. This is just one of the many workflow models that we have. And we have a very basic workflow model, but then it walks through the trade-offs associated with each. So a reason why you might want to use this, what are the advantages of using this, and what are the potential trade-offs of that particular model. So you can see that all in Chapter 5 of our toolkit. There's also some slides in here in regards to how you can use similar strategies in picking your workflow model to then help you figure out how to respond to needs. So there's some slides relating to that. And then I did want to show the importance of data visualization, that this is a great engagement tool that you can use with your staff and leadership, that if you're able to show like how many screens you've done, or on the left is a chart to show the number of Prapare assessments completed by each staff or provider panel, you know, that helps encourage some like friendly competition amongst the staff. That's kind of a good motivating technique. You can see how many you've collected over time, that you can really like do a lot with the data visualization. So I don't know if you guys use tools like Tableau or even just Excel, just to show your staff like all the different ways that you can really use this data. I'm sorry, this is showing up a little blurry, but this is from Colorado actually, and this like gives you a sense of like what are the most common needs in your patient population, how many of your patients are experiencing this need. You can filter this data by your diabetic patients or your hypertensive patients, and then see kind of like what the main needs are amongst those populations. So it really just kind of makes this data really actionable as well. So I'm going to stop there. There is my contact information. I'm happy to take more questions if there are, but you're also welcome to email me. We on the National Prapare team are more than happy to help you guys and assist you. I think we'll be talking more with the PCA about other things that we can do to help support you guys. But just never hesitate to reach out. That we want to, we're all on this journey on social determinants together. And again, I think you're probably already doing a lot that you're not giving yourself credit for. But it's really helpful. We all work together and learn from each other. So thank you so much for having me.
Thank you, Michelle, and thank you to everyone for attending today's webinar. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate if you complete that and provide your feedback. On behalf of the Nevada Primary Care Association, thank you for joining us today, and have a great rest of your day.